as far as community involvement and research, uh, in our particular project, emphasizing the ACURE study, the community was involved from the very beginning, from conceiving the project to creating budgets to working on interventions to working on recruitment. The community was wholly involved. And when you think about it for a minute, in traditional research, you have an expert with a conceptual model who designs an intervention off that model and expects it to work as if we're in a laboratory. And that might be a good model for a mice experiment or for designing a drug. But when you're talking about human behavior and you're talking about the delivery of health services, it's far more complex than that. So you not only need the academic expert and the conceptual model, but you need people with lived experience who are on the ground, who have faced barriers, who have fought through with resilience and crafted their own solutions. And you need that as part of the equation. You need to take advantage of everyone's expertise. I mean, participatory research means what it says, and again, it's taking advantage with those who have on-the-ground, very granular experience, as well as lived experience, who have experienced barriers, who have experienced institutional racism, and understand the systems that they've had to overcome. And when you combine that with technical knowledge and how health systems work, how electronic health records work, how institutions set up what they do, by combining all those viewpoints, you have the chance of a really beautiful product as well as stakeholder involvement right from the get-go. Way back when, in 2002, when the Institute of Medicine report came out on unequal treatment, a Greensboro community member, a black community organizer by the name of Nettie Code, was just so moved by the stark disparities described in the report that she really wanted to do something about it. And she brought together different community members who had experienced adversity working with the health system, and she brought together people who were decision makers in the health system, and then she brought together academics, and we all met together in a way to really put our heads together and craft a solution and figure out how best to penetrate the stark and widespread disparities that had occurred not only in Greensboro but across the United States. When you have people who come together with different backgrounds, if you're not using the same language and you don't understand the systems as they are, it's really hard to communicate and come up with a solution. And so we underwent something called racial equity training that was back in 2003, was actually called Undoing Racism, and was the teaching was given by an organization from New Orleans called the People's Institute of Survival and Beyond. And in that training, it reflected the history and the development of not only racism and race-specific laws in the country, but sort of how racial disadvantage worked in institutions. For instance, we learned about redlining, we learned about school suspensions, and we learned about the health system and all the broad disparities as well. So once you understand that this isn't a problem of individuals who are, quote, racist, this is a problem of a system functioning so that some people are disadvantaged and advantaged, you look at solutions as a system base. So in other words, it's not just one person with implicit bias who prevents everybody from getting care, and if you teach that one person about implicit bias, the problem goes away. It's a matter of building in transparency so you know immediately when there's a disadvantage, and accountability so that when that disadvantage is seen, there are system-based solutions to overcome that disadvantage so that everyone gets excellent care. There were several things. First of all, there were community members who would shadow clinicians and clinical functions during the cancer care process. And in that shadowing, the community members were able to point out where things were working well and where things weren't working, and problem solve where corrections and stepwise processes could be better and communication could be better. The second thing was during the study, we would present both interim results of the study and interim results on recruitment to community members, and people could comment on why they thought things were going well or not well as the process went forward. So there were several iterative midterm corrections we made to make the intervention product even better. And I'd go into great detail about the intervention product, but there's a whole module on that, so I won't right now. But the other thing that was really important is again, this is an intervention, cancer treatment, that affects the whole community, and so the community needs to know about the disparities to start with. They need to know about the solutions being delivered, and they need to know the end result. So ultimately, there needs to be accountability to the community, to the public, on how health systems are doing. The collaborative is still working on disseminating the great results we had in the ACCURE study for system-based intervention in cancer treatment, where everybody, both white and black patients, had better treatment completion as the intervention went on. But the collaborative is thinking about chronic disease management, about cardiovascular risk, about diabetes care, about many other health disparities that are going on, and thinking about how to craft similar solutions for these chronic problems that have resulted in many unnecessary deaths and bad events over time.